Okay, so we are gonna start by just a moment. Okay, so if anybody can take this one to describe what she sees in this echo. This one here.
مرحبا دكتور حاتم.
Yeah,
I
hello.
can take it.
Yes, go ahead.
Okay. This view is the apical core chamber view, with or and without color.
Good.
Okay. I see dilated left atrium.
Yes.
There is mitral regurgitation.
Good.
Concentric mitral regurgitation.
Could you tell how much? A bit tough, right?
Severe mitral regurgitation.
Based
severe
on
MR.
eyeballing of the jet.
The jet?
Yeah.
Yes.
Yeah. That's an impression, right? So it will be largely speculative if you just rely on the jet eyeballing. That's why you should always, if possible, employ some quantitative measures like the vena contract, the jet, the flow convergence, the width PISA, and the volumetric assessment. But if it's
the reversal,
really severe, you might, yeah, you don't need to go for, but sometimes you need quantification even for severe mitral regurgitation, okay, for procedural purposes and stuff like that. Did you observe that the septum here is also abnormal, the interatrial?
Aneurysmal, yes.
And that indicates
aneurysmal.
Pressure overload. Possibility of being bound to the right side is
to the right side, yes.
Yes, and this
due to volume
arises from, yeah, exactly. So it's like because of the pressure or volume overload here, because of the mitral regurgitation, possibly. What do you think about the LV function?
LV also dilated with reduced function.
Yes. How much reduction in the LV systolic function you could tell about?
I can say 40%.
Maybe lesser.
Okay, 35%.
Okay.
Because the image it is not clear, I can't.
Exactly. Yeah. But you did so well in this case, actually, and it's more or less global. Though we are not seeing all the segments in this view, we are seeing the lateral, the apical, and the inferior septum, but all of them are uniformly hypokinetic. Okay, so this is kind of global hypokinesis. If I tell you that this patient is the same as this patient after a few months, what do you think about the MR? And I froze it here. I froze the MR here and here. You see the MR has decreased a lot. The LV function has improved a lot.
Improved, yes.
So what do you think the reason may be?
Okay, it can be patient has received optimized medical therapy.
Okay.
He could, if the cause is ischemic MR, he may get a revascularization.
Very good.
And the third, it can be mitral repaired, underwent surgery repaired.
Very good. Yeah, these are actually the three possibilities. And the possibility or the cause of this dramatic improvement or interval improvement in MR and LV systolic function in this patient was something so unusual. It was just dialysis. So it was just dialysis. Can you explain that? You know, this is a patient actually who was
overloaded.
Yes, exactly. So it was metabolic cardiomyopathy due to the metabolic derangement. And he was doing dialysis, in fact, but was probably not optimal, because when we intensified his dialysis, and after 1 month of this escalation of dialysis, the MR has actually disappeared or become just mild, and the LV function retained to normal. So this is one of the reason of reversible severe mitral regurgitation and reversible cardiomyopathy by metabolic derangement. So we should always take it into consideration, because, you know, if you discuss this patient probably in your meeting, some of you might elect to go for surgery, right? Surgery. Yeah, yes. Exactly. So we should always be addressing the reversible cause forward, assign or delegate the patient to some procedural and surgical intervention. Okay.
Okay.
Good. Now, this is a patient showing in the 3 images. It shows one complication. Can you tell me about it? One complication. This one, and it is shown, of course, here in 3D. So amazingly nice, with annotation telling you that this is a piece of meat called papillary muscle attached to the cord and flapping into
papillary muscle rupture.
Yes, exactly. This is papillary muscle rupture. You see it here, and you see the MR tends to be eccentric, and this is the papillary muscle rupture, which is a mechanical complication of which muscle is likely to rupture more than the other, and why?
Medial.
Why?
Because it have a single blood supply, coronary blood supply.
And anterolateral has dual.
It has dual. Okay, yeah.
Yes, yes. The dual blood supply of the anterolateral comes from where?
From the diagonal of the LAD.
Okay.
And the OM.
And the exactly.
Yes.
You're right. Now, clinically, how do you think this patient? Clinically, the patient is likely to be seriously sick with hemodynamic crashes and that. But clinically, by clinical examination, you are so unlikely to detect a murmur. Okay. You agree or disagree?
Agree.
Yes. And that is why?
Because the LA didn't the complaints of the LA.
Yes.
Because it's an acute. Yes.
Yes, yes, you're so right. يعني هي طبعا نحن usually يعني what is pronounced about the murmur is the intensity and duration of the murmur, both of which are relates to the difference in pressure between the LV and the left atrium. But when the left atrium is small and compliant and with high pressure, that will rapidly equalize the jet. So the jet will be soft because it will be short in intensity. I mean, slow in intensity and short in duration. So it's easily missed clinically. I mean by clinical. Okay. That's why we have to do transthoracic echo if we are suspecting mechanical complication. That does not apply to VSR. VSR, which is ventricular septal ruptures, tend to be clinically pronounced. You are going to elicit a murmur, a thrill, a
loud murmur.
Yes, but the MR can be easily missed clinically for these reasons. Okay.
Yeah.
And what is this? If you look here at this transthoracic echo, how could you describe this echo? Forget about the T on the right. Just listening.
This is a perforation of the anterior reflex.
Okay, perforation. Any other opinions? Sorry?
Usually the left atrium.
Yes.
With reduced LV systolic function. filial mitral and anterior mitral leaflet.
Okay.
With LVH.
Could be chordal rupture.
Good. But what do you think that the primary pathology in this valve?
It is second and shortened or tethered.
Okay.
Could be rheumatic.
It's very good, by the way. That is so good of you. You nailed it, actually. This is an echo of a 16-year-old gentleman. He came actually with fever and intracranial bleeding due to mycotic aneurysm. Okay. We didn't know about the history of rheumatic in this patient, but his echo showed this, and we did TEE. We didn't find vegetation, but we found a flail anterior leaflet and severe mitral regurgitation. Exactly. So that was a case of infective endocarditis, and probably the vegetation had destroyed the valve, leading to this chordal rupture and flail anterior leaflet on top of chronic rheumatic mitral. Okay. Sometimes you don't find the vegetation, but that will not rule out infective endocarditis, because in this patient in particular, the culture was positive and he had mycotic aneurysm and all of that. Okay. So that was a case of infective endocarditis. Now, for infective endocarditis, what other complication are you expecting إنها تحصل للvalve?
The valve can have an abscess.
Okay, it's an abscess.
Fistula, pseudoaneurysm.
Okay.
If valve is a prosthetic or mechanical valve, it can get stuck.
Okay, good.
Or paravalvular leak also.
Okay. Very good. And perforation as well, right? So you said
yes.
ممكن يحصل chordal rupture. ممكن يحصل chordal rupture, like you said.
Like this case, yeah?
Yes, exactly. ممكن يحصل perforation. And ممكن يحصل paravalvular leak in the bioprosthesis. ممكن يحصل like an abscess, periannular extension of the infection, and all of that. The final result of this damage على valve إنه بيحصل regurgitation. It's quite unlikely إنه يحصل لك stenosis. Right? Stenosis مرات بتحصل because of bulky vegetation. I'm going to show you an example. ولكن غالبية الأحيان the damage of the valve translates into regurgitation. Okay, rather than stenosis. Okay. تمام كده؟
Yes.
Are you following with me? Okay, good. طيب. Now, this abnormality can be associated with all except. Now, what you are seeing here on this echo could be associated with severe mitral regurgitation, Lvot obstruction, apical thrombus, normal coronaries, severe AR. We need one wrong answer. So, any guess about what this echo about?
It is, I think the diagnosis is LV non-compaction. No?
Not really.
Okay.
Maybe yes, the apex is heavily trabeculated a little bit, but that's not compaction. But if you compare the basis of the heart to the mid and
septal hypertrophied.
More than that. Look at the
apical aneurysm.
Apical hypokinesia.
Aneurysmal apex.
And if you focus further, it's more than apical aneurysm. Actually, the aneurysm starts from the mid downward.
Yes.
So both the mid segments and the apical segment.
Yes.
Okay.
Compensated hyper.
I think.
Sorry.
Normal coronaries.
We need to mute or.
What do you think, Yani? What's the? Okay, I need some.
Please mute your mic.
Okay, that's okay. Good. Yeah. So, okay. So, what do you think about what this echo shows? It might be infarction, right? It might be anterior.
Yes. Yeah.
eccentric hypertrophy. Eccentric hypertrophy.
Eccentric hypertrophy. It's very difficult to tell. Then eccentric hypertrophy, you have to have the anterior septum in view and the posterior portion, compare between the two. So it's probably it's prostenal lumbaris, not apical 4. But here we see that clearly that there is hyperkinesis in the base and severe hypokinesis.
Hypokinesia in the apical, yes.
Cavity.
So almost probably fracts.
Sorry. Yes, Fikri, go ahead.
No, I'm just thinking about ischemia, boss.
Yes, ischemia is one is one possibility, or another Takotsubo. Yes, these are the two possibilities.
Yes.
Here. Of course, we are gonna deal with this echo like the most serious thing, which is ischemia, MI, and take the patient to cath lab and see. But you might find that it's quite normal, and that's retrospectively is the diagnosis of Takotsubo. So in either case, whether this is Takotsubo or acute anterior MI leading to apical aneurysm, are we gonna find severe MR? MR is a possible association with this morphology.
Well, since it is an apical hypokinesia more than the base, the MR is not really that much possibility, I think.
Mm-hmm.
If I'm not mistaken.
It may affect the annulus.
Mm-hmm. Good. It might affect the annulus. Yeah, I agree with you. But if it affects the annulus, I would be expecting that the base
it will be affected.
Okay, but here the base is hyperdynamic and of
yes.
But still, you know, the mid cavity, if you look here at the cursor, the mid cavity is here where the papillary muscle anchors. Okay, so it might be pushed apart and that leads to functional MR. So it can be functional MR due to displacement of papillary muscle, or it could be MR due to some other mechanism. I'm gonna tell you shortly. Lvot obstruction. Are you expecting Lvot obstruction as a complication of Takotsubo or anterior wall MI when you are having apical hypokinesis and hypercontractile base?
No.
No.
Unlikely.
If as a compensatory mechanism by exaggeration of the function,
okay,
leading to some sort of hypertrophy.
Okay, right. And I'm happy that I brought this one here because Lvot obstruction is one of the complications of such echo or LV wall motion abnormalities. I have seen a couple of cases and they are missed. The last case was of a patient who crashed after acute anterior wall MI, and they were suspecting mechanical complication. Okay. So we were looking for MR and we found none. Actually, I sent the fellow echo to do the TEE and he called me that things are fine, no MR, no VSR, nothing. And I asked him to send me the videos and I was astonished to see gross abnormality that might be the reason for dynamic crashes, which is completely missed by the fellow, simply because of, you know, this the so-called satisficing premature closure anchoring bias, because his mind was set on excluding MR VSR and he doesn't look
VSR. Yeah.
It was complete Lvot obstruction by SAM. So SAM can be created by this dynamics when you have a hypercontractile base and a hypokinetic mid and apex that will create as if you have two chambers, one of low pressure, one of high pressure, and that can create Venturi effect, which is gonna suck the anterior leaflet into the LVOT, obstructing it. And that can be so severe, leading to hemodynamic problems. So LVOT obstruction is one of the mechanical complications of acute MI. Remember this one, okay? So when we talk about mechanical complication of MI, we focus on VSR and MR, but LVOT obstruction is also a mechanical complication you should be on the lookout for, okay? So severe MR is likely, LVOT obstruction is likely, epica thrombus is likely, of course. Normal coronaries, if it's a Takotsubo, yes, but severe AR is unlikely to be associated with such echo. Okay, so that's an easy one.
It's tough one.
Okay.
No, it's tough.
Is it tough?
Is aortic dissection? There is a dilated aortic root with dissection flap.
So
Double valve signs.
You see my cursor here?
Yes.
My cursor. Okay, what is this?
Yes.
Dissection flap, right? Okay, you're right. I lost you, Ryan. I lost you. Are you still there? Hello?
Yes, yes.
Oh, yes.
I'm following Mr. Hatim.
Tamam. So this is a dissection flap. This is a dissection flap. Okay. And what is there any dissection flap here?
I can't see it.
You can see. Anybody can see any dissection flap in the image 3 at the bottom? By the way, it never fails me, this image, by the way. Every time I show it to fellows, they miss.
والله يا دكتور حاتم صعب جدا عليهم.
In the upper part?
Descending aorta.
Yes, very good. Thank you so much, Abdullah. طبعا يعني of course. You know, نحن طبعا يا اخوانا بالذات that's human nature, by the way. يعني we are so prone to making error, especially when we are confronted by an abnormality, a big abnormality, يعني you know, hitting us right in the face. We tend to be blinded or confused about seeing anything, and this is satisfying. لكن واحد من المشاكل إنه we don't usually focus on this black hole down here, which is the descending thoracic aorta. So if you don't see a dissection flap there, you might see it here.
Yes.
Or sometimes you can see a dissection flap that goes all the way up and down here. Okay, so don't forget to look down here. Okay, so now here, this is dissection type D. This is type A and this is type A. So in dissection, the MR, you might have severe MR, and that severe MR is either due to the dissection flood, like here, is interfering with the coaptation of the valve, or the dissection flap and the dissection in general dilates the root, is splinting the two cusp or the three cusp apart and leading to functional sort of aortic regurgitation. So aortic regurgitation with dissection type, I mean type A dissection, it might be due either to the flap going down into the aortic valve plane and interfering with the coaptation, or due to the dilatation of the aortic root. Now, what other abnormalities do you see? This is again, I might say self-satisfying because you focused on this and you forgot about seeing anything else. But there is something so serious here in the mitral valve. Mitral valve.
Fecal valve.
What else?
Prolapsing the posterior leaflet.
It's kind of flail.
Bilateral prolapse.
It is either severe prolapse or flail of the posterior leaflet here. So the mitral valve is myxomatous with redundancy and prolapse or flail of the posterior leaflet. So expectedly there will be severe mitral regurgitation. So all in all, this patient might be a case of what?
Marfan.
Marfan syndrome.
Yes, Marfan. Thank you. Okay, so now anybody can take this. Okay. If you see here, I think this is typical. This is so typical.
الكليبس بتمشي slow ولا
بالله الايمجز ماشيه slow.
slow.
Do you have the same problem with the images?
أنا قلت يمكن مشكلة بتاعت الشبكة لكن
All of you have the same problem? Huh?
Yes. Some slowness.
It
أيوة.
So I don't know. Let me see. Okay, I think right. Let me see here. Do you have the same problem here? This is fine. This is okay.
Yes, this is okay.
Oh, okay. So probably this is because of GIF. Like no problem. We are gonna skip it. So. Right. Because you don't see it well.
No, I think it was okay. I don't know. It was no problem. There was, if I'm not mistaken, there was an prolapse of the anterior leaflet. Yes, it was.
Fikri thinks that there is prolapse of the anterior leaflet with severe eccentric MR directed period. Any objection or support? Type. I'm gonna challenge
flail or
yeah, Fikri and Rayan, if you wanna support Fikri, this is not a case of prolapse.
But thickened. I think it is thickened stiff.
There is something moving with the anterior mitral leaflet inside the left atrium, I think.
Oh, if you think that's the one, this is not. This is just an artifact. But if you focus now, look here. Type. Okay. What do you think about the LV? The LV is dilated. Look at the posterior.
Dilated.
The posterior.
Yes.
Compare the posterior wall to the anterior wall.
Yeah, not moving. Hypokinetic.
Really hypokinetic here. Look at the posterior leaflet. Compare it to the anterior.
Thickened and tethered.
Yes, exactly. So it is tethered. Okay. So this is ischemic mitral regurgitation.
Okay.
Yes. The MR we are seeing here is due to the traction, okay, and tethering of the posterior leaflet rather than the prolapse of the anterior leaflet. It's not absolutely wrong. لأنه here, when you have tethering of the posterior leaflet, that will create sort of relative prolapse of the anterior leaflet. Okay. So the anterior leaflet is relatively prolapsed. It's not truly prolapsing, but it's relatively prolapsing when you compare it to the retracted posterior leaflet. Okay, and as we know that, you know, the trap rule of thumb towards restriction away from prolapse. So the MR jet goes away from the prolapse towards the restriction. So if you have restricted posterior, it goes towards it. If you have prolapse anterior, it goes away from it. So trap towards restriction away from prolapse. Okay. Now, when you want to quantify the mitral regurgitation, when it's eccentric, it's a bit tough. You agree or disagree?
Yes.
Why is that?
Because it's hugging the wall, not the jet.
Mm-hmm. Yes, you are so right. That is called wall hugging jet, and the wall hugging jet can lead to underestimation of severity. Because you know what, when you have, if I take this one as a valve, say this is the valve, the mitral regurgitation goes this way. Let's say it is central jet, okay? What we are seeing by color Doppler is not the primary jet, it's the primary jet and the secondary jet. The secondary jet is called entrainment. It's very difficult to write it. So what we actually see by color flow map is the primary jet and the secondary jet, which are created by the kinetic energy of the primary jet exciting the blood around it and recruiting blood into the MR. So it looks like mosaic color. Okay. Now, so it all depends on what? It depends on the velocity of the primary jet. The higher the velocity, the more likely it recruits more of secondary jets, and that is gonna widen the jet. So central jets appear wider because of entrainment. Now, if we compare that to an eccentric jet, here is the wall, let's say, and the jet comes and hits in the wall. When the jet hits in the wall, it loses kinetic energy. So when it loses kinetic energy, the entrainment around the jet will be just small, and that's why it appears small. Deceptively, it appears small, okay? So remember this Coanda effect because of eccentric jet. And that's why in eccentric jet, you better go quantitatively and check the vena contracta and go by volumetric assessment and stuff like that, because the jet map itself, the jet mapping might be deceptive, okay? Good. Okay. We go further. Now, what do we see here? Any guess? Anna, I want you to be familiar with the new procedures and the persona of the new valves and new procedures, you know. So this is a case of TAVI, okay? And this is how the TAVI valve look like, okay? It looks like this. So it has a personality which is different than the pyroprosthesis. It's a stent like, I will give you a session in echo soon next week. I'm going to show you all of these valves and how they look like. But this is a TAVI valve. And what do you see about this TAVI valve? You see here anteriorly? You see anteriorly? Mm-hmm. Do you see this part here?
Yes.
There is a jet, right? That is paravalvular leak coming anteriorly, okay? Another thing in this patient, a few days after TAVI, he did worse. And we didn't know why. And clinically, there was no pulmonary edema as such, but he was extremely shortness of breath, even much more than what he had before. So we did this echo and we found that he had paravalvular leak anteriorly, but most importantly, he had a high gradient across the mitral valve. His gradient here was 9, 10, or sorry, 8 to 9, something like that, at a heart rate of 70, 80. So could you explain why? Why the mitral valve can be affected in TAVI? Any guess?
If it deployed down.
Sorry?
If the valve deployed and not in place.
Yes, exactly. Yes, you're right. You're right, yeah, Muhammad. So like this valve is low-seated valve. You see, the valve is not supposed to go that much down. So the valve is low-seated. And the low-seated valves has two problems. First, it will not snug so stiffly in the annulus, leading to paravalvular leak, like in this patient. The other thing is that it might encroach upon the anterior leaflet, like it does in this patient, and lead to variable degree of mitral stenosis. If you see the 3D here, I'm showing it to you. You see the anterior leaflet is here, the posterior leaflet is here. See, the anterior leaflet is not contributing to opening anymore because the valve is encroaching upon or impinging upon the posterior, the anterior leaflet, keeping it semi-closed. Okay, so that's the problem of low-seated TAVI valve. Okay, paravalvular leak on one side, and it might encroach upon the integrity of the mitral valve, in particular the anterior leaflet. Okay, now, any guess? I hope the video is working normally to you. It's fine now, right? It's not hiccuping anymore, right?
Yes.
Okay, so now what do you think about this one here? Huh? You want me to zoom in or magnify the image?
Yes.
Okay. Mm-hmm. What is this?
Looks like a myxoma.
Okay, yeah. So this is a patient, a female, middle-aged. She came with shortness of breath, and this is her transthoracic echo, which is showing a mass. And when we traced the mass, we found that it really originates from the interatrial septum. There was no stalk, actually. It was broad-based. But the mass itself was kind of irregular, and, you know, التكشر بتاعتها is heterogeneous, and we thought this is myxoma. The patient, of course, had an obstruction in the mitral valve due to this mass effect, and she underwent mass excision. And what else did she undergo? Sorry, yes, valve implantation. This is bioprosthesis, right? This is bioprosthesis. Okay. Unfortunately, the histopathology of the mass came back as sarcoma, not myxoma. And the patient was handled by oncology, but she refused to go for chemotherapy, and she came a few months later with this mass. So the mass حصل فيها recurrence, but this time is below the valve, which is newly implanted, and worse, it is obstructing the LVOT completely. You see the TE here? You see that the mass is completely blocking the outflow. You see it here?
Yes.
Yes. So that was a recurrence and of a sarcoma. It's a rare case, but sometimes masses might present acutely with obstructive lesions leading to acute hemodynamic effects like this patient. Okay. Now look at this one here. Ignore this here. Look here. Of course, again, the image. I'm challenging you, but it's really tough. I might map out the structure. This is the LV, okay? This one is the LV. This is the left atrium. And this one here is the LVOT and the aorta. This is apical 3 chamber. So what do you see in this apical 3 chamber?
2 direction jet.
Huh?
There is a jet.
Yes, you're right.
2 direction bilateral jet.
Okay. Yani it's continuous jet, right? It's systolic and diastolic, yes. Yeah. So what could that be? What could that be? Sorry?
It looks like a rupture sinuses.
Rupture sinuses, maybe, yes, but rupture sinuses into the left atrium.
It's not common.
Likely, yes.
Yeah, common.
I might make it easier for you. This patient just 4-5 days post AVR metallic. AVR is
the rupture of the anterior mitral leaflet, perforated.
Now look at the anterior leaflet. The anterior leaflet is here, down here, but the flow is coming above the leaflet and above the aortic valve itself. It's above the aortic valve.
Septum.
I show you. Sorry, septum. Yani, look at it here. This is the aortic valve. This is the mechanical aortic valve here. You see, mechanical aortic valve. That's the anterior leaflet. Now I have flow that comes from the aorta into the left atrium. So what is it?
Fistula between the aorta and the left atrium.
This is fistula. Aortoatrial fistula, okay? And this is a complication of infective endocarditis. And in fact, we found that this patient is having vegetation and infective endocarditis. Now, this, if you look here at the TEE, it might be any better explaining the anatomy. You see the aorta is here, and the flow is from the aorta above the valve into the left atrium, continuous flow because of the aortoatrial fistula, which is most likely the complication of infective endocarditis because it leads to liquefaction and necrosis of this area and it can rupture. Having said that, it might also be technical, by the way. Yani sometimes ممكن يكون because of faulty surgical technique, you know, something is pierced in here, okay, and you might have this fistula. But more frequently to be infective endocarditis related than any other factor, like in this patient. Now,
Victor,
yes.
Can you tell me how you differentiate? It's not, I mean, sinus opening here. I know it's not a common to find rupture sinus in the LA, but is there any way to differentiate between fistula and rupture?
Fistula and rupture, no. Here the fistula is in fact a rupture. Yani the fistula is just a tract between two chambers which are supposed to be independent and not communicating. Now they are communicating. So I would say that this is a rupture or a rupture tract between the aorta and the left atrium. So if you call it rupture, that's not wrong, but it's called fistula, aortoatrial fistula. Sometimes they call it aortocameral fistula because, you know, sometimes if you have vegetation and abscess here, that abscess might rupture in the left atrium, it might rupture in the right atrium, it might rupture into the pulmonary valve itself or the pulmonary artery. So it can rupture in any direction, but more frequently or more commonly to rupture into the left atrium if it forms a fistulation than to rupture anywhere else. Now, for aneurysm, it might rupture. The aneurysm usually tends to go rightward than leftward. So it usually ruptures in the right chamber, right atrium, right ventricle. And the other thing about the rupture or the aneurysm, in the aneurysm, you are not gonna see a continuous flow like this. You are gonna see a distorted anatomy, a very dilated sinus, like in here, very dilated sinus, but the color is uniformly going in the right direction. There is no color that transects the boundaries going into the other chamber. That is if there is aneurysm, sinus aneurysm without rupture. But if there is rupture, you are going to see exactly this flow. You are going to see it exactly. The only additional thing that differentiates between the two is the aneurysmal dilatation. You will see aneurysmal dilatation and rupture. But here, I don't see any aneurysmal dilatation. In fact, I see thickening here, thickening. And this is a sign of abscess formation, phlegmon, collection, okay? So when you see this one here, okay, like this, then it becomes necrotic with cavitation and echolucency. That's an abscess formation with fistula. But if it's aneurysm only, aneurysm, coronary sinus aneurysm, you will see that there is a dilatation of the aneurysm, okay? And then a rupture. That's the difference between the two, okay?
Thank you so much. شكرا لك يا دكتور حاتم.
You are most welcome. So, what is the problem in this patient? This patient is having an acute valvular disease. What is this acute valvular disease?
AR.
Acute AR.
Why? Why? So why did you say acute valvular regurgitation? I think that was Sarah.
Yes, me. There is a diastolic flow in the continuous wave Doppler.
There is
that is
here, this one here.
Yes. With a sharp deceleration time, very sharp.
This one here.
Yes.
Okay.
And also on the M mode, there is this is a mitral valve with premature closure.
Yes, very good. This is premature closure of the mitral valve. And please, when we talk about the premature closure of the mitral valve, let's think of it as this one. And if you look at this one, which is more common slide, actually, I've seen it a lot. Yes, this is the fluttering of the anterior leaflet plus premature closure. So the valve is supposed to open this way. I'm going to show it to you. It's supposed to open that much. And then here, like now it is prematurely closed. It's forced closed before it opens fully. And that's because of what?
Direction of the jet of the AR, hitting the anterior. High LB.
Thank you so much. Thank you.
The AR.
Is
The jet
not
of the AR.
Exactly. So it's not, it is not because of the direction of the jet hitting here. No, that doesn't close the valve prematurely. It might induce fluttering. But the premature closure is due to the elevation in the LVEDP. That's why the valve closes prematurely. Okay, good. So if we go here, now we see again the valve is closed prematurely because it's supposed to be like this, and then we have here. So it is closed prematurely. This is one sign of severe aortic regurgitation, especially the one associated with high LVEDP, which is either the decompensated chronic or the acute AR. So when we see this one, we are either dealing with severe aortic regurgitation decompensated or acute severe aortic regurgitation. The other sign of severe and decompensated or acute severe AR is here. I think Sarah thought this one is the pressure half time of the AR jet, but this is not the AR jet. This is the mitral inflow. You see, I can map it out for you. That's the E, and sorry, here is the A. You see it? So it's E and A. So this is the mitral inflow, not the pressure half time. But you are right, the pressure half time, when it is like this one, when it is like this one, it is so different. The shorter the pressure half time, معناتها the higher the LVEDP, leading to a rapid equalization of the pressure and cessation of the backflow. So the pressure half time, if it's lower than 200 milliseconds, indicates what? High LVEDP, and that means either severe acute or chronic decompensated AR. Okay, but this one here, as I told you, is the mitral inflow. And again, it shows a sign of severity, which is what?
Diastolic dysfunction.
Diastolic dysfunction of grade 3-4, exactly.
And
yes.
even there is MR.
Sorry?
MR.
What's the problem with the MR?
يعني it means they also there is a high LVEDP.
The MR itself? Or something special in this MR jet? Look at this MR jet. Yes, thank you so much. There is diastolic MR, you see? You see this part, the initial part, this one is diastolic. This part is diastolic MR. And diastolic MR again signifies high LVEDP. So these are all signs of high LVEDP. The premature closure of the mitral, the high E over A ratio, and the diastolic MR. Okay.
And there's no B pump here?
I didn't see it, but the P pump also is a sign of high LVEDP, along with the short pressure half time of the AR jet.
Yeah.
Okay. So let's take the eraser, erase all this. Okay. Now, so the famous slide of the difference between hook'em and fixed aortic stenosis. Which one is hook'em? Which one is aortic stenosis?
The first one is aortic stenosis. The second one is hook'em.
Okay, great. Yes, the first one is aortic stenosis. The second one is hook'em. Yes, because what is important here, if you see that the gradient is not a discrimination between the two. The gradient here, after the PVC, if you compare this gradient with the baseline gradient, it gets higher in fixed AS, and it gets higher also in hook'em. So the gradient gets higher in both. So the gradient changes is not going to show the difference between the two. But what is going to show the difference between the two is the pro-compro sign, which is what exactly what is it?
Increase pulse pressure in case of hookah.
Increase or decrease?
It's actually decreased in hookah.
Yes, exactly. So if you compare the pulse pressure, which is here, this difference between the systole and diastole at baseline, compare it here after the PVC. This is the diastole and this is the systole. So there is shortening of the pressure difference between systole and diastole after the PVC in hookah, but not in fixed aortic stenosis. And this is exactly the pro-compro sign of hookah. Okay. So once you see this one, so always focus on the change in the pressure difference after the PVC. If it shortens, that is hookah. If it lengthens or remain the same, that is fixed aortic stenosis. There is another sign here that tells that this is aortic stenosis and this is more likely to be hookah. What is this sign?
The shape of the aortic trace.
Exactly, the shape of the aortic tracing. Could you elaborate further?
Spike and dome in the hookah.
Slow rising pulse. Pulses tardus, parvus
Yes.
tardus.
Very good, Awia. So you know this delay here, which is pulsus tardus. That is pulsus parvus is something clinical. Like in parvus, when there is the epislope of the aortic valve, of the aortic pressure, is distant from the LV pressure. There is a delay because of the severe aortic stenosis, so it opens a bit after the LV contraction. That's why there is a delay, and this is called tardus. That doesn't happen with hookah, because in hookah, we don't have any fixed obstruction, okay? So the flow is going, but it's impeded by a muscle, that hemodynamically or dynamically by a muscle. It's not like this one. So we don't elicit this tardus pulse in hookah, okay? And also sometimes if you focus further, like in this one here, and in this one here, you see that the pulse wave takes this morphology, right? Spike. What is it called?
Dome.
Spike and dome.
Spike
Yes.
and dome.
Spike and dome. Spike and dome is so characteristic of the hookah waveform, the hookah arterial waveform. But the most specific sign, as we said, is the pro-compro sign, which is the pulse pressure shortening after the PVC. Okay. So you get this one? For a reason or another, this one slide is, for the exams, yani, they loved so much this one and the difference between restriction and constriction in invasive hemodynamics. These are the two most commonly hemodynamic tracing cropping in the exams. Right. Now, what's the problem here? What is the problem? Yes. Okay, so it is an MPI, right? So it's a SPECT study.
Yes.
And yeah. So what do we see here in this SPECT study?
There is reversible ischemia in the inferior lateral wall.
Sorry, I'm so sorry. I'm so sorry. This is not SPECT, this is PET, okay? And this is perfusion Okay, and this is metabolic, perfusion, metabolic, perfusion, metabolic. And as you see here, they are using ammonia for the perfusion scan, and they are using glucose for the metabolic scan. So what are they testing here? What are they testing?
The viability of the tissue of the myocardium.
Okay, the viability. So do you think it's viable or non-viable?
It's not viable.
It's not viable.
It's viable, taking
No, it is viable because in the FDG it takes the tracer.
Okay. Here, let's first define where the perfusion defects is.
it's much.
Where is the perfusion defects?
In the
Anterior.
anteroseptal.
Ah, okay, yes, I
There
agree.
is no uptake.
Yeah, anteroseptal, like you said, and probably also here anterior and apical. Okay, and here is also apical, right? So it's LAD ischemia or infarction. Now, when we see the metabolic scan, we see that the anterior area is shining here. And if you see here, it's also, when you compare it with the metabolic, it's uptaking the FDG, and the apex is also start to shine through. Okay, meaning that these areas are of low perfusion, but they are metabolically still active. Okay, so that indicates what? Viability. So this perfusion, and this is metabolic scan. So we call this one perfusion metabolic mismatch. Mismatch because we don't have perfusion, but we have metabolism. So when we have a perfusion metabolism mismatch, that indicates viability. When we have a perfusion is absent and metabolism is absent, this is perfusion metabolism match, and this is non-viability. In this case, we elicited viability in the LAD area. Okay. So this is how they test for viability by PET. So PET is about eliciting that this seemingly infarcted or hypoperfused tissue is metabolically active.
Hibernative myocardium.
Yes, exactly. Here the definition of hibernation. Hibernation, يعني مثلا بقول لك smart heart hypothesis, where the heart, when it's confronted with ischemic challenges, it down-regulates the metabolism and it down-regulates the contraction and everything, right? Trying to survive this kind of ischemic challenge, okay? So it's a smart heart hypothesis theory and stuff like that. This is the hibernation, just like الكمون اللي بيحصل للأنيمالز. طيب, how could we know إنه the heart is hibernating or it's actually dead? If we demonstrate that this part, which is dead looking, is metabolically active, معناته it's not actually dead, it is hibernating. And this is what PET does. Now, other ways of assessing viability in cardiology are another three. We can also do SPECT, we can do MRI, and we can do echo, okay? SPECT will define viability as the uptake, increase in the uptake in the low perfused area, and this indicates that we have intact membrane and intact mitochondria. So the definition of viability in SPECT is the intact membrane and mitochondria, assuming that if you demonstrate that there is uptake, which depends on the integrity of the cell membrane and the mitochondria, meaning that tissue is viable. That's the hypothesis upon which the viability testing of SPECT is based on. Now, echo, the hypothesis of viability depends on eliciting contraction. So I have a low contraction or no contraction in a segment, And I activate these segments by inotropic challenge. If I demonstrate that this segment is coming into contraction, that means it's viable. The last thing is the CMR, which is cardiac MRI. Cardiac MRI define non-viability or viability by the amount of fibrosis by the delayed hyperenhancement. So the more of fibrosis, the more the likelihood of viability. So you see now we have 4 mechanisms of viability assessment. PECT and PET, the integrity of the cell membrane and the mitochondria. The PET, how this hibernating tissue is metabolically active. Echo, by demonstrating the contractile reserve. CMR, by demonstrating the amount of fibrosis in the tissue. All of these can be used for viability testing, لكن طبعا the gold standard now goes for CMR, مع انه كان الجولد ستاندرد لحد وقت ما بعيد يعني كان البيت، ولكن الان CMR if it's available it's the gold standard. Okay. The most specific actually I would still say, and that's my own impression, like it's supported حتى by a lot of studies, the most specific of viability among كل ال 4 modalities دي شنو؟ The most specific. Specific means low false positive. Yani there is no way you miss it. If you say that this is viable, it's likely it's viable. It cannot be false positive.
Bet.
vitamin the most
because vitamin echo, you know, I don't care about metabolism, not metabolism, cell membrane.
The contractility can be detected.
I'm gonna induce contraction. If I induce contraction, يعني انت زي مثلا واحد الان يعني you wanna wake him up. If he wakes up, start to shiver and come back, that's يعني خلاص, you know, it's a clear sign that he is not dead. Now I'm gonna elicit contraction, which is so gross, you know. Like sometimes, yani, it might be that the cell membrane is intact, the mitochondria is intact, but the tissue is still dead. It's not gonna come back. Okay, it might be metabolically active, like in the contractility will not come back. Yani, these are possibilities. لذلك eliciting إنه في return of contractility is probably the most specific. Okay, ولذلك الفيتامين ايكو ما زال السبيسيفيسيتي حقته probably the highest او قريبه او معاه بتاعت السي ام ار، هم together are the best two. لانه السي ام ار برضه it sees how much fibrosis, clear fibrosis in the wall. Seeing the clear fibrosis in the wall and seeing the contractility elicited in the hypo or akinetic segments is more specific than metabolic and more specific than integrity of cell membrane. And this one, like here, this is CMR, and you see
that's the question.
Yes, of course.
How we assess an area in percentage in the nuclear? I mean, we face a lot that they mentioned that, for example, area more than 10% of ischemic area. This is, for example, indication for revascularization. How we measure an area affected by ischemia in nuclear studies?
Yes, in nuclear study they have software. طبعا you see here طبعا هنا what we are usually showing in exams and in discussions. We are showing the polar map. I mean the perfusion map, which is this one here. But there is a lot of other data seen by the nuclear cardiologist, like polar map, ejection fraction, the contractility in systole and in diastole. And here in this polar map, the segments which are hypoperfused will come in percentage by the software immediately. Okay, so they know exactly how much of ischemia is there according to the entire polar map, because this is the polar map which represent the 17 segments. So anything like this one here, the blue, okay, is defined as percentage out of the entire polar map. So you get exact percentage of ischemia versus normal. So this is software game. Software game. It's not you don't do it manual ولا حتى eyeballing. You do it by quantification by a dedicated software for this kind of quantification. Okay. حتى TID which is transient ischemic dilatation بيجيك هنا في software exactly the difference in this donut circle or gap between stress and rest, exactly how much ratio, 1.5, 1.9, and this is all software quantification. Okay. Now, if the CMR, like it shows you how much of fibrosis here. You see the fibrosis is defined by the delayed hyperenhancement and how much it involves from the wall. Yani if that's the wall here, طبعا ischemia, like we said, it always starts subendocardially and it goes epicardially. For what they do is they evaluate how much of delayed hyperenhancement. If the delayed hyperenhancement is only here subendocardial, معناتها is still viable. Lakin when it occupies more than 50% of the wall thickness, this is so unlikely إنه يكون viable. أو مرات حتى يكون transmural, like this one here is transmural. So there is transmurality of the delayed hyperenhancement. So in CMR, it's about the transmural hyperenhancement. How much? More than 50%, it's unlikely to be viable. Wadaya studies has shown that the amount of our transmural extent of hyperenhancement correlates with non-viability. يعني شوف هنا لما تكون 70 to 100% compared to 50 and 70 compared to 25, 50, the more of involvement of the wall thickness, more likely the muscle is not viable. And 50 is a threshold. More than 50 is non-viable. That's what you have to remember. Don't bother yourself with the figures and stuff like that. More than 50% of wall thickness involvement by delayed hyperenhancement is non-viable. This is how CMR checks for viability. Okay. Now, what is this?
Mitral clip.
Mitral. Mitral clip.
Okay. Good. This is mitral clip, and I brought this one here for explanation because it's important. Now you also know about the percutaneous intervention, which is included in the new science of a structural heart disease, which is growing so fast, by the way. And حتى نحن we are so dizzy to catch up with this kind of fast advances in the structural heart disease. So now they are doing mitral clip. There is also tricuspid clip. Okay. So the most important thing here is, that when you come with the clip system on the left side here, this one, you see the direction of the clip has to be perpendicular. And this is so important. You have to be perpendicular. You know what I mean by perpendicular? So this is the anterior leaflet. This is the posterior leaflet. You see, you have to be perpendicular. Yani, if these are the two leaflets, if you are seeing my hands, you have to come this way. You don't have to be oblique, because obliquity will affect the efficacy of the grasping and it might risk detachment. So that's why you have to come perpendicular. Checking perpendicularity is by TE. So T is going to check the perpendicularity. And then the clip system is going to be passed down to the LV. And you see when the clip comes where the jet is, and the imager is gonna tell the operator that you are hitting where the MR is. Because if I come in an area and the MR is coming from a different area, shall I go and clip this area? No, you have to move your clip, you know, along the plane of the valve to grasp where the MR is. Okay, and this is all imager information. So the imager is gonna tell the operator how to move to catch where the MR is the biggest. Okay, so is it medial? Is it central? Is it lateral? So that is so important. That's why CLIP is basically TE guided procedure 100%. Okay, so the success of the CLIP depends on the imager first and foremost. Now, what is the indication for mitral clip in the guidelines? Because you remember the newest guidelines. Yes, just few months. Sorry, again.
Heart failure at the part of management of severe MR
Yes.
and heart failure.
Yes, exactly. Heart failure management. Okay. And what else? And if I have a patient, 47, had an ejection fraction of 40 and severe MR, will I take this patient for mitral clip? So I want sorry, Go ahead.
Palliative therapy for the severe MR.
Severe MR in what?
Ejection fraction less than 30%.
In what kind of patients? Not necessarily.
It is for secondary MR.
Low ejection fraction patients.
It is for secondary and primary.
With the high surgical risk.
Yes, thank you so much. حتى كمان مش high بس prohibitive surgical risk. يعني when patient is so high risk for surgery, that's the option. So option I mean the mitral clip is reserved for patients with extremely high surgical risk as decided by heart team. So the heart team should sit together and decide about each patient individually, how high risk this patient is and whether the mitral clip is suitable or not. So it's the heart team decision. But basically mitral clip is for high surgical risks. So not for all patients. Okay. Now what is this procedure? What is this procedure?
TAVI.
Not TAVI.
Aortic balloon pump.
No.
This is valve involved.
Yes. This is valve involved. Yes. So valve involved is now an important part of the structural heart intervention where you have a bioprosthesis. So you have to have a solid platform upon which you lay your new valve. So if you have a bioprosthesis in the mitral or in the aortic position and it gets degenerated and the patient is high surgical risk, you can go by a bioprosthetic valve new mounted in a catheter, and you go down here, okay, and you position your valve and you inflate it against the old valve, and that's all. It's an easy procedure, easier than the clip. Okay, so this is again valve in valve. Sometimes they do valve in MAC and valve in ring. Yani if the mitral valve has ring, you can also put a valve in this ring under certain condition, not for all. So you have to make sure that the ring is more than 170 circumference, stuff like that. There are some calculations. Also, if you have mitral annular calcification, which is, you know, circumferential, you can also put valve in MAC. But these are a bit tough. It's not valve in bioprosthesis. Valve in bioprosthesis is easier because the platform provided by the old valve is solid enough to take the new prosthesis. But the mat and the ring are not. Okay, but they are also done valve in mat, valve in repair ring, and stuff like that. So this is valve in valve. Okay, again, high surgical risk patient. Now, what is this procedure? What is this procedure?
This is occluder for leakage, also paravalvular leak.
Exactly. Yes, very good. This is the plug, which is implant sort of a device. Again, this is a percutaneous intervention. Like here, if it's a mitral valve, they go through the septum and see where they pass their wire, where the leak is, and they put something that looks like implant there to close the defects. In this case, it was the mitral valve here. This is the LA appendage. You see this hole here. This is the LA appendage. The septum is here. So this is more or less anteromedial paravalvular leak, which is closed by a plug. This is again a procedure, percutaneous procedure, which is percutaneous occlusion of paravalvular leak. So this is the scope and the landscape of structural heart disease. Mitral clip, طبعا TAVI is, is taking off so high. TAVI is one. Mitral clip, tricuspid clip, valve in valve, and percutaneous closure. Okay. Last one is this one. So what do you think about this patient? What is going on here? I need a smart guess. Look at here. Forget about the color. Look at this one here. First of all, tell me what
anterior
is
mitral leaflet perforation.
Anterior mitral leaflet perforation.
It looks like a aortic valve.
Okay, so you think that this one here is a bioprosthesis, right?
Yes.
Bioprosthesis in the aortic valve. Okay. So how about the mobility here of this, stability of this prosthesis? It doesn't look stable, right?
Yes, it is rocking.
It's a bit rocking, exactly. It's a bit rocking. And when it's a bit rocking means that you have a wide dehiscence. And here the color has shown that this jet here is a paravalvular leak coming from anterior. You see here, even I see slit, there is a gap here. And through this gap comes this huge paravalvular leak. And that slit was big enough to cause instability in the prosthesis and this rocking movement. Okay, so that was a patient who came with shortness of breath and all of that, and he underwent surgery. I mean, redo surgery, because when the valve is kind of rocking and the gap, the leak is through a big gap, probably surgery is the way to go, especially in this patient who was relatively young. Okay, so he went for redo surgery successfully. Okay, what do we see here in this chest X-ray?
Precardial calcification.
Yes, this is precardial calcification, and this chest X-ray states the fact that when you are dealing with the anterior posterior and posterior anterior orientation, you might miss it. That's why if you are suspecting calcification, lateral X-ray is the way to go. Lateral X-ray will show you the calcification much better than AP and PA orientation. Now, this is another type of calcification, but for a different reason, and that is
Aortic and
yes,
aneurysmal
this is aneurysm. because you know the configuration takes kind of aneurysm like this one here. So when you have an apical aneurysm, it can be calcified. Okay, so this is a calcified apical aneurysm. Okay, and here the calcification can also be detected by fluoro. By the way, fluoro is great in calcification, in detecting calcification. Okay, so whenever you are doing your cath rotation, try to be broad-minded and look beyond the boundaries of the coronary angios. So the LAD calcification can be seen. Stent can also be seen. Precardial calcification can be seen even much better than X-ray and can be seen in all orientation. MAC can also be seen like here. This is mitral annular calcification, you see. So you could see calcification nicely by fluoro, okay? Dry fluoro, that is dry fluoro. You know, I'm not injecting any dye, dry fluoro, okay? By dry fluoro, you could see the calcification in the coronaries. You can see stents, you can see precardial calcification, MAC, and all of that. Now, what is this?
IRL, loop recorder.
Exactly. So this is implantable loop recorder. The most commonly used one is the reveal device. Okay, so it's put here to monitor. It's loop recorder. It's called loop recorder. Why it's called loop recorder? What's the meaning of loop? Loop recorder.
Loop is a loop. Continuous recorder for quite long time.
It
can be for years.
And by the way, it's not recording continuously. It's looping. Looping means it's recording and erasing, recording and erasing. So لأنه الdevice itself فيها limited storage memory, and that's why it function as, you know, recording and erasing, recording and erasing. And that's why, you know, the patient had a remote control, right? And you should coach the patient that to press on the remote control every time he feels the palpitation or the symptoms we wanna work them out. When you do that, the signal is gonna be picked up by the reveal device, and it's gonna freeze the recording before, during, and few minutes after the patient press on the button. That is gonna be stored in the memory unerasably until you come and check on the device. But otherwise, if you don't press, it keeps recording and erasing, recording and erasing. Yes, okay. Okay.
Okay, boss.
Now, what is this device?
CRTD.
CRTD. بس not ICD, CRTD. ما if you say CRTD ممكن تقول لي by vent by vent ICD, I might accept that. But if you say CRT, you said CRTD.
Yes.
Yes.
CRTD, yes. Okay.
Yeah, incorporate the ICD, yes.
Yes, exactly. So it is resynchronization and defibrillation. And this one is the coil of the defibrillator wire in the LV. And I have an LA lead. And this one goes to through the coronary sinus to the lateral venous branch. Okay. This defines the resynchronization. So if you are looking for whether this device had a resynchronization mode or not, look for this wire. Okay, the wire that is crossing to the left side of the heart. Now, what is this?
Localized pleural effusion.
Yes, localized pleural effusion, or حتى ممكن يكون insisted fissure effusion. Sometimes they call it pseudoaneurysm. I have seen one of a patient who came with this mass, and next day after Lasix infusion or the Lasix injection, it disappeared completely. That's why they call it sometimes pseudo tumor. Okay. Now, again, I wish so much you remember the difference we discussed between the pulsus alternans, which is beat-to-beat variation, and the pulsus paradoxus, which is a decreased arterial pressure during inspiration. Okay, so this is so important. Now, when you see a tracing like this one, the first thing you should describe it as pull back. Pull back. So pull back means I have one catheter and I am pulling it back from a chamber to another chamber, getting different tracing consequentially as I am moving backward. But if you have simultaneous, meaning I have two or more catheters, that's why I get tracing simultaneously, LV aorta, LV mitral, stuff like that. So this is pull back from the LV to the aorta to the aorta. So now what I am seeing is aortic gradient. Aortic gradient.
Yes.
So that is coarctation most likely. If you say supravalvular aortic stenosis, might also be right, but this is aortic gradient. Now what is this? This is a simultaneous tracing because I have two catheters, one in the RV and one in the RA, measuring pressure at the same time. So I have RA catheter, and this RA catheter shows me what?
High RA pressure.
Exactly. But why is this high RA pressure?
It is the large V wave.
Exactly. So the one that reaches up there is the V wave, and that is severe tricuspid regurgitation. Now what is this? This is again a pullback. If you compare it to this one here, it's different. It's pullback from the LV to the LVOT to the aorta. So the gradient is elicited where? Between the LV and the LVOT. So this is what LV gradient. So this is Hookham. Okay? It's not like that one. That one was aortic gradient. This is LV gradient. Okay? So this is Hookham. The other sign of Hookham is the spike and dome pulse morphology. Okay? Thank you so much.